Hi, Cynthia.
Hey, Scott.
Good to see you by the beaches of Hawaii.
Thank you. So it's all in my imagination. It's a
Uh,
wonderful thing about a virtual world.
yeah, much of what we're doing nowadays is in our imagination.
Right.
Let's welcome everybody to the fourth Feedback Informed Treatment and Deliberate Practice Meetup. We are so glad you're here. Cynthia will be monitoring the conversation, and as always, all the information that I'll be talking about and Cynthia will be sharing today, you can find on my personal website, which is at scottdmiller.com. Remember the D in between Scott and Miller. The last 5 or 6 blog posts have been about working in the new world, dealing with COVID-19, how to administer the measures online, etc. There's lots of helpful advice. Several of our certified trainers have also provided how-to videos. In addition, the recordings for the first 2 webinars are available already on my website. You can go there and listen to them. You don't have to listen to the entire thing either. We've gone through them and specified the questions that were asked and the approximate time in the recording that that particular question is addressed. And I'm about to hit the button to publish my latest blog post, which has the recording from the 3rd meetup. In addition, thanks to Mark Holtz at ceunits.com, it is possible if you are a clinician in the United States to earn an hour of CE for this particular event. You can go to the website and look for the link below each video to do that. These webinars are always free. There is a charge from CE Units to get the credit if you're interested. I think it's 15 bucks. So thanks for the questions that you all submitted in advance. I've listed them out, and Cynthia and I have pulled together some slides and material to answer. And let's start with Pete Mosley's question. And it's a lovely question. He asks, how have I, he's referring to me, sustained my interest in FIT and DP over such a long period of time? And, you know, I think back about how long I've been in the field. The pictures that you're seeing here are over the course of my career. The first one to the left is a workshop. I actually remember this particular workshop. It was in a small town in an area called Småland in Sweden. The town was Jönköping, and this particular picture was taken in 1992. And I was talking about, I believe, solution-focused work. Our book, Working with the Problem Drinker, had just been released. The middle picture is actually from a workshop in the UK. I'm lucky enough to be able, in good times, to travel there a couple times a year. And this was for an NHS workshop. I believe this was about 2000. And then the picture on the right is from the last Evolution of Psychotherapy conference. And I have to tell you, I've just been so happy that people are willing to follow me on what's been a very personal journey over the course of my life and career, trying to get better at doing therapy. For me, from the time I entered graduate school, I was never a natural therapist, I promise you. Many of my colleagues seemed to understand how to do therapy. They understood the concepts. They understood how to be in the room with people and not feel overwhelmed and anxious. That was not me. I needed step-by-step guidance to feel somewhat comfortable, especially when it was obvious that I was beyond the role play with a colleague phase and actually faced with somebody who was suffering. So I wanted to know what to do. I didn't feel like I got much clear information or skills about that while I was in graduate school training to be a psychologist. So I have pursued that for the last 35 years through several different phases. I started with a particular treatment model. The data came back and said that that particular approach was effective, but it wasn't any more effective than anything else. That was truly dissatisfying to me. So that particular job ended, and I met up with some other colleagues, and we began to explore the common factors. We figured, well, if it's not the specific model of treatment that makes a difference, then maybe it's what they all have in common, because the data seemed to suggest that all approaches in general worked about equally well. At some point during our work together, the group that was working on the common factors figured out that it was an empirical dead end. That's right. The common factors were an empirical dead end. We wrote 2 books about it. It was a bit embarrassing to have written so much and then figured out that it wasn't going to lead anywhere. But I think it was Mark Hubble who called me one night and said, wait a minute, what we're saying makes no sense. If all approaches work equally well, why would understanding the factors that make them all equally effective encourage anyone to learn about those factors? Why not just keep doing their particular model? It was a scary realization. So in that particular period of time, we were influenced heavily by a former professor of mine, a guy who wrote letters for me to get into graduate school, Mike Lambert. Mike Lambert was measuring outcomes. He was primarily concerned with negative outcomes. For me, I just wanted to figure out, was I effective or not? So we began working on developing a measure. That became, of course, the ORS and the SRS. Initially, it was just about measurement. But soon we found that we could use the information we got from clients on a session-by-session basis to begin making changes in the care. Randomized clinical trials followed, and feedback-informed therapy was born. But I still wasn't satisfied, because we found that getting feedback might help the therapist help the client at that moment. But it didn't seem to result in the therapist getting any better. And actually, this was an insight from Mike Lambert. Mike Lambert did some very clever studies where they used therapists as their own controls. What does that mean? It meant that in those studies, with half of the clients, a therapist received the feedback. In other words, the measures were administered and feedback was provided. Your client is on track, off track, or at risk. With the other half of their clients, the measures were administered, but they got no feedback. They weren't told whether they were on track or off track. So it's the same therapist, just working with or without feedback with different clients. What did Michael find? He found that after 3 years, therapists who'd gotten feedback on half of their cases were doing no better with the clients that they didn't get feedback on. Let that sink in. Because what it meant was the therapists weren't learning anything from the feedback. And that was a real puzzle. It was a game stopper. Michael was struggling that. Our team was struggling to understand that. And about this same time, another phenomenon popped up. I'm just following my bliss here. I'm just following where the data is taking me. And that phenomenon was certain therapists in our ever-growing database seemed to achieve outcomes that were superior to everybody else, sometimes by a full standard deviation. This was not a small difference, it was a huge difference. And what's more, it didn't matter who they saw, what the problem was, what country they were in, etc. They seemed to be helpful more of the time. At first, I honestly thought, and I think our team believed as well, that that difference was a chance variable. Certainly, people wouldn't be able to be winners year after year. And when we looked at the data, there were some that were great one year and then okay the next. But for the most part, top performers stayed top performers. And we wanted to know, how did they do it? We watched their videos, we did interviews, and I have to tell you, we couldn't figure it out. And then one day, I was sitting in a middle seat flying back from Europe. I believe I was in Scandinavia. I was in one of those extra tired states. I didn't have a movie to watch, and so I reached into the pocket of the seat in front of me, and in there was a magazine. It was called Fortune magazine. It's a magazine for obvious reasons I'd never read before. Jeff Colvin interviewed a person whose name was Anders Ericsson. Anders Ericsson, he called the expert on expertise. I'd never heard of the person. He was a Swedish-trained psychologist who'd been looking into expertise for 30 years at that particular time. He was studying chess players, computer programmers, teachers, physicians and surgeons. And his whole interest was in, why were some better than others? Well, his actual interest was, why are most people who spend their entire lives working average, but a few end up superior? And of course, you know the end of this story. He found that one key factor that separated the best from the rest was the amount of time that those performers spent in this activity, deliberate practice. Deliberate, meaning intentional, and practice, meaning successive refinement over time. It was an eye-opener. When I read this particular article, I went back to the team and started talking about deliberate practice. And it just so happened, I ran into a person who was a student at the time, a psychologist from Singapore named Daryl Chow. And Daryl was willing to do his dissertation looking at the impact of deliberate practice in psychotherapy. And of course, what he found that the best therapists, those in the top quartile of effectiveness, were spent 2.5 times more time engaged in deliberate practice. And in fact, that's what our new book is about, Daryl and me and Mark Hubble, called Better Results. So Pete, I hope this answers your question. I'm assuming that my interests will continue to take me in new and different directions. If you saw or heard about the presentation I gave at the last Evolution of Psychotherapy conference, it was on bringing magic back to psychotherapy. After all, our field has magical roots. We talk about it as if it's completely scientific, but we come out of a healing tradition that dates back, well, a millennia at least. And so I've been really intrigued about how we can expand the frame beyond just Western notions of healing and helping. So again, thanks, Pete, for that particular question. It's nice to go down memory lane. Then let's go ahead and move on to the next question. And this was submitted by Robert Phillips. Robert, thanks for asking this question. And I hope that I understood what your question is about. If I didn't, then feel free to jump back in and send a follow-up note to Cynthia. He asks, is it possible to use one measure across different contexts? So this is interesting, and it usually comes up, if I've understood the question correctly, when people are thinking about measuring either within particular cultures or across problems or treatment centers. And the ORS is in fact a measure that is designed to be used across problem types. But to understand why, it might be helpful to step back for a minute and think about how fit fits within our current treatment paradigms. So there are two different paradigms in operation. The dominant paradigm guiding clinical care, that is mental health care in the Western world, is the medical model. And the medical model assumes that there are some specific ingredients within a treatment approach that are remedial to the problem being treated. What do you have to do in order to treat correctly? You must know the person's particular diagnosis or problem. Otherwise, you might give them the wrong treatment containing ingredients that aren't specifically remedial for that particular problem. That's the medical model. There's nothing wrong with that model. The question is, does psychotherapy research support that idea? Of course, that medical model leads to evidence-based treatments. I've got to follow a particular protocol that contains the ingredients that will solve that particular problem. What's critical for the clinician to do? What's critical is that they adhere and they have fidelity to the treatment that they're offering. And the best sign of success is remediation of the symptoms associated with the diagnosis, syndrome, or problem. That's the way I was trained. On the other hand, there is an emergent model. These words owe their origin to a former professor of mine, an ongoing mentor, Bruce Wampold. It's called the contextual model. And in the contextual model, the emphasis is not on the diagnosis or problem. The emphasis instead is on well-being and functioning. Is the client functioning well in their current environment? And instead, therefore, of having treatments that fit the diagnosis, the question is, do the treatments fit the client and engage the client? Instead of adherence to a particular protocol, what's more important is that the therapist has an allegiance to it, that they believe in what they're doing. That belief fosters hope and expectation on the part of the client. Hope and expectation from the medical point of view is viewed as placebo. In the contextual model, it's viewed as a central healing element. And in the contextual model, perhaps if we push the paradigm a little, we wouldn't have evidence-based treatment so much as evidence-based therapists. And let's take a look at how each one thinks about the results. Again, we're both shooting for an outcome. And on the medical side, we're interested in disorders, which we first have to identify, determined by the particular symptom pattern. And then, as a result, if we want to measure the outcome, we'd have to have multiple specific measures, one for depression, one for anxiety, one for PTSD symptoms, etc. Well, again, the question is whether the data fits that model very well. So if Bruce were here, he would say over the last 30 years, not one interaction has been identified between a particular diagnosis and specific treatment approach to indicate that any specific ingredient or technique or model works better than any other. Does that mean you don't need them? Of course not. What it means is that you have to believe and have a structure and a focus in your work. But the real aim is not remediation of the particular symptom pattern, but an improvement in well-being. Again, that's on the contextual side. And here's the curious thing about these two different paradigms. Symptoms have never been a very good predictor of whether or not clients decide to enter therapy and when they decide to leave. Now, if you just think about this for a second, I think the truthfulness of this statement, the factualness of it, will strike you. Many people wait until they've had symptoms for a very long time. What explains that fact? A fact that drives the professional organizations crazy, that treatment providers spend a lot of time talking about. What explains it is that people tend to come to treatment when their symptoms affect their functioning. So having a drinking problem is not the same as it affecting your relationship, your ability to make a living or get along with your children. So this is why in FIT, we've chosen to move over to the contextual side. We're measuring client functioning because it tends to better predict when people enter and exit from the therapy process. That's essentially what the outcome rating scale is designed to assess: individual, interpersonal, and social well-being or functioning. Again, the lower the scores, the greater the likelihood that the client will end up in care, choose on their own, or have someone else who's worried about their well-being send them to care. And as well-being improves, the greater likelihood that the client will begin to space out contact or even end the contact altogether. So, Robert, I hope that we've managed to get a little bit of what you were looking at with this question. So where have we been so far? First off, FIT is a continuing journey. If you take anything away from the first 10 minutes of this particular webinar, it should be FIT is not a fixed entity. We haven't stopped evolving and developing. We are moving constantly, partly because I want to follow where the data takes us, and partly because our experience tells us that what we're talking about right now really isn't the full and complete picture. So let's move along then and answer a question that many of the people who are on today's webinar had. Claire Wild, Evelyn Bro, Raylyn Wicklin, Georgina Stratigaku, Mary Lewis, Aaron Todd, Nola Butler-Bird. Hi, Nola. Bill Robinson. Hello, Bill. Lydia Mack, Singa Schnevo, Lisa Ruthling, and Danielle Carey. All of you had the same question, really, and that is, what is the best way to incorporate or implement the scales into your practice and also enter, monitor, and evaluate out? Good question. And if the question is how to get started, then I think there are a couple of steps. The first one is simply go to my website and download the measures. When you get the packet, inside are the tools in about 30 different languages. And also included now is the Taxonomy of Deliberate Practice, or the TDPA. That'll be useful when and if on this particular broadcast we get to the topic of deliberate practice. But so once you've downloaded the scales, the next thing is to figure out how to use those scales usefully. And I think the single best and most efficient way to do that is to access the feedback-informed treatment manuals. Again, those are available in the online store on my website, and there are 6, everything from soup to nuts. The first one lays out the empirical case for working in a feedback-informed way. It is a trans-theoretical description. Doesn't matter if you're doing psychodynamically oriented work, CBT, or ACT. And it actually doesn't even matter if you're doing psychotherapy versus counseling, or maybe even case management. These manuals will describe the empirical foundation. Manual 2 tells you how to administer the scales. Manual 3 covers supervision, which we're going to get to in a moment. Number 4 is how to interpret all of that data that's going to emerge when you begin using the scales. Manual 5 is special applications, including cultural adaptations when using the measure. And Manual 6, which probably should be read after Manual 1, especially if you're working in an agency, is about implementation on an agency level. I would say this is the best way to get started in using the scale. Third thing to do is to join the ICCE. ICCE, the International Center for Clinical Excellence, it doesn't cost anything. And Cynthia and I have lamented over the previous 3 broadcasts that this platform, which is essentially a combination of YouTube and Facebook for fit practitioners, remains underutilized. But if you go there, join, create an avatar, an identity on the site, you can ask a question and the thousands of members that we have around the world will reply, sometimes 2 or 3 within 20 minutes. So I strongly encourage you to go to ICCE to get the support that you need. And then last but not least, check my blog. Every week to 10 days, I put out a new blog post. You can also use the search feature to search through various odd blogs. On there are also some videos and interviews that I do with people on a routine basis. One person in this particular group asked me about using the measures in the time of COVID-19. And if you read right here on the screen from March 23rd, this blog post is about using the measures in an online format. And that's also the topic of the blog post from March 31st. And as I said, some certified trainers, Stacy Bancroft and Brooke Matthews, created some how-to videos for how to administer the tools, whether you're using one of the online, the official software programs or not. One last thing I should mention is that when you download the measures, there's also a script that you can use for administering the scales orally. Again, if you're not using one of the online platforms, because they allow you to email the measures ahead of time, to complete them while you are online as well. So you can use a particular script where you can read the items to the client that you're working with and get them completed in that fashion. The 3 authorized systems, the FIT software tools that you can see down here in the lower right-hand corner, are Fit-Outcomes. This is a company in Denmark. My Outcomes, which is a Canadian company, and OpenFit, which is an Irish company. You can see that we are an international community working together. Each one provides a free trial. My advice to people who are beginning to implement is to take advantage of that free trial. I think they last anywhere from a month to 2 months. You can sign up, you can get your feeling for whether or not the platform works for you. And each one has a slightly different personality and bells and whistles. And the costs are slightly different, although really they're pretty close. Cynthia, you think I've covered everything with regard to the systems and online services?
There are a couple of questions that came in though, so
Okay.
maybe I could just bring them back. The first one's from Andrea, and it actually goes back to the topic you were talking about before when you were looking at the medical versus contextual model.
Okay.
And she's just asking, can you put it into a clinical context, like a clinical example?
Let's just think about a client who comes in, and I'll take one from my work. For much of my professional life, I've worked with clients who have a dual diagnosis. So there's usually some mental health and a substance use issue. And from a medical perspective, I might then need a measure for depression, and I might need a measure for alcohol abuse. The assumption is that if drinking goes down, well, then that is a successful resolution of the problem. Or if depression scores go down, well, then that's a successful resolution of that particular problem. But interestingly enough, in both instances, decrease of symptoms doesn't necessarily mean that the client's functioning has improved, which is baffling to our field. And that's because, again, most people don't go to treatment because of their symptoms or problem. That's our language. That's what we turn it into. Instead, it's when those particular symptoms begin to impact their functioning. So their partner is complaining, their relationship is falling apart, they feel bad about themselves, etc. So I could either have a specific symptom measure for each issue that people come in with, which means as a clinician, I have to have a whole stack of measures, one for each diagnosis in the DSM. Or I can simply measure the client's well-being. And that's exactly what we do in FIT. In FIT, the client comes in at the very first visit, and what they get is the ORS. I ask them to fill this out, and they are measuring their well-being in each of these 4 areas: individually, interpersonally, socially, and overall. And when those scores fall below the clinical cutoff, which is 25, these clients are likely to experience benefit from talking to me. And as those scores begin to climb, interestingly enough, their problems, both substance abuse and depression, tend to become less and less important matters to them and less frequent. In addition, as the well-being scores go up, it turns out that the client's interest and motivation for staying in therapy begins to decline. So changes in well-being allow me to titrate the dose and intensity of treatment much more carefully and usefully in a way that has predictive validity than simply measuring the abatement of symptoms. I hope I managed to get the question. A related question is about how often to use the measures. And I think it's Risha Fleming. She asked, do you use the forms every session? And the answer is yes. So if you're thinking as an adult outpatient clinician, where you're likely to be seeing clients once a week, and that's an interesting topic we should talk about as well. But if you're seeing clients once a week, then I'm going to give the ORS at the beginning of the session, and I'm going to give the SRS at the end of each session. And you may wonder why, or might not the client get fatigued from that, etc. So the answer for why is I never know if the client is going to return or not. Secondly, I have to make sure that I am addressing any particular alliance issues before they leave so that I can increase the chances of them returning. Now, let's nuance this a bit. If the client scores are super low on the ORS, the average entry score, by the way, is 19. But if I'm getting scores down around a 13 or a 14, that's fairly low. And I know that since they're so low, that the probability of early change is higher. Those scores are likely to increase sooner. That means maybe I can increase the dose of care. With those clients who are super distressed, it makes sense to offer them more service rather than less service. As the scores approach the clinical cutoff, it makes sense, given that the trajectory of change, the speed with which they're going to change over time is lengthened, to spread out the dose and intensity of treatment. Now note what we're tailoring the dose of treatment to, not the number of problems, not the number of symptoms, but the distress level, which gives us an idea about how quickly or how slowly the client is to change. Higher scores, it's going to take a longer time to experience some benefit from the treatment. If I give them lots of sessions and the scores are at or near the clinical cutoff, to both the client and you, it's going to feel like not much is happening. So I can successfully spread out the contact a bit. The lower the scores, I'm using that as an indication that I can actually increase the dose if the client wants. That's if you're working in an outpatient setting. What happens if you're working in a group and you meet the person, say, 3 times a week for that particular group? And just so you know, there is a special scale that can be administered in a group context. The ORS is exactly the same, and I'm going to administer that at the beginning of my group. And then I'm going to use the data to guide the discussion. I guess I'm sort of an old-fashioned group therapist. I'm not running educational groups, rather. I'm running more traditional process-oriented groups. People are coming because they have an issue and they want to take part in the group experience, sharing with each other, both the support and perhaps some confrontation about what they might need to do differently. So the ORS is the same. And outcome, as I said, is used to guide that experience. Then at the end of the group, I'm giving the group SRS. The group SRS assesses several different levels of the alliance. The group leader to the entire group, the group leader to the individual member, and the members to one another. And I'm going to leave time at the end of that group to process with the clients their scores on the SRS. The same way I would do if I were running a traditional processing group. I'm just doing that processing with the structure given by reviewing the scores on the SRS. Now, let's go back to the original question. What happens if I'm seeing people 3 times a week? Well, in that particular case, they probably will be fatigued if I ask them to fill out the ORS and SRS at every single group. The main reason is that there's not going to be much change between Monday and Wednesday. So what do you do then? Our recommendation, and what is in Manual 5 of the FIT manuals, would be to give the ORS at the beginning of the first group of that week. So if you're meeting Monday, Wednesday, Friday, I'd give the ORS at the beginning of the first group, and then I would give the SRS at the end of the last group. This treats the entire week as the unit of service. Yes, there are 3 discrete groups, but the real treatment was this entire week of group services. On the SRS at the end of the week, I'm going to be reminding people to think back over the 2 prior groups as they fill in the measure. Now, I know what you might be thinking. You might be thinking, well, wait a second. What happens if they felt positively disposed towards the last group, but not this one? If somebody raises that concern, I say, perfect, put 2 lines or mark it twice, because then I can explore the difference with that particular person. The same goes for an inpatient setting, which is a question that was also asked. Are you going to measure a person every day? Because lengths of stay within inpatient settings are often very brief. The answer to that question is no. And I've been impressed with several agencies in the United States and abroad that are managing to get an initial ORS the minute the client is brought into the inpatient setting. And we know that clients can come in a variety of states. But for example, Lake District Mental Health Agency in New Zealand, Joanna Price, who is one of the nurse managers there, they are getting the ORS completed right as people come through the door for that first visit. But again, I'm not going to want to measure every day. So I might measure the first day, the 4th day, the 8th day, or the last day of their hospital stay. When I'm measuring at the end of their stay, I'm trying to facilitate a good transition to whatever service is going to follow their inpatient stay. Those were the questions of nearly 10 people actually about using the measures in a group context and implementing them in their practice. Cynthia, how are we doing?
Yeah, there's actually been a few related questions that have come in as well. So since you're looking at the group session rating scale right now, and I've just talked about that, I'll go to that question first and then go to the other one. So Sherry is asking how to use the measures in groups, which you've talked a little bit about, but I think the issue is that she says she runs a teen group and is using the measures, but while people fill out the form and at times will write a comment, they don't speak up during the group.
So first thing I want to say, Sherry, is thanks for taking the risk and trying it out. Secondly, thanks for working with teenagers. I think this can be a really challenging group because if you're not a teenager anymore yourself, it's a different culture that you're entering when you're working with that population. And so what do you do with groups? The first advice is don't forget what you know about groups. all you're doing now is adding measurement to the process. So let me give you a couple little hints, and I can't take credit for these things. These are from my background in running groups and also in helping people talk who might be hesitant to speak even in one-on-one therapy. The first piece of advice is small ask before a big ask. Small ask before a big ask. What I mean by that is I'm going to ask a little favor before I ask for a big one. So let's take the end of your group work. First thing I'm going to do is I'm going to pass out the measures and I'm going to remind them of the culture of feedback. We work a little differently here. We're really interested in making sure that what happens here in this group works for you. It fits for you. It keeps you engaged. If it is, that's great. We want to know. But if it's not, we also want to know that. And we don't want you to look for some grand failure here. We're trying to fine tune and tailor this. So even if it's a small thing that you think isn't worth bringing up, mark the form accordingly and then let's all talk about it. The first thing I do is I ask them to fill it out. It's a small ask. Then there's a slightly bigger ask. Here's that ask. Then I say, so would you now score them, and who scored above 36 by show of hands and who scored below 36 by show of hands? So I'm building responsiveness slowly. I first do the culture feedback, I ask them to fill out the measure, and then I ask them to vote. Who's above 36, who's below? Those above 36 are saying that the group went relatively well. Those below 36 and below are saying there may have been concerns they had about the group. Now I've had them vote, and then I turn to the group as the group leader because I want them talking, not me, and I say, where should we start, group? Our discussion. Should we start with the people and hear from some of the people who thought the group went well? Or should we start with folks who might have some concerns or for whom the group didn't fit very well? And then I lean back in the chair. Now remember, they've already raised their hands. That's one way. Another way is an old Gestalt strategy. And that is, if you've tried the hands and it doesn't work, I ask people who scored a 37 or higher, so above the cutoff, I ask them to pull their chairs into the center of the group, leaving those who scored below around the outer circle. Now think about that for a second. Now I've called attention to the fact that not everyone felt the same as the in-group. And then I start to talk with the people in the inner group. What went well? And generally, as I do this, most people, someone will say, well, what about the people on the outside? And then I'll say, oh yeah, what about them? What should we do with regard to those folks? Well, don't we need to hear why they scored low? Why don't you ask her? I then say. So I'm just using a natural group process to facilitate a discussion via the SRS at the end of the group. And you can do the same thing with the ORS at the beginning of the group. Whose score went up? Whose score went down? Where should we start, group? And then I'm working my way out of a job. I'm trying not to talk while they process and help the people whose scores went down, or they celebrate the people whose scores went up. I hope that gets it, Sherry. Thanks for that question. How we doing, Cynthia?
Larry is asking if you could restate about the ORS cutoff statement again.
Okay, so the cutoff on the ORS is at 25, and it is the dividing line between those who are likely to benefit from care, that's below the line, and those who are not likely to show measured benefit from care. For adults, that's a score of 25. Now, let's take a look at another graphic here, and I'll show you about how this relates to change. The lower the score at intake, and I'm trying to put my cursor on the screen so you can see it, the lower the score at intake, that first session, the earlier people tend to report change, and the more change they report from start to finish. You get a steeper arrow. The higher the score goes, the longer it takes people to experience meaningful change, and the less change they experience from start to finish. You can see that in the arrow. All this means is that I can begin thinking. This isn't a decision I make. I don't look at the graph and say, okay, I'm going to see you every week. I just am not that kind of a clinician. Remember at the beginning, I told you I'm an anxious clinician. So I'm going to negotiate this. I'm going to be transparent with the client and talk about this. Uh, if the client scores are somewhat higher like this, then I might suggest that we meet every other week and talk about the amount of work that needs to go in between sessions. If the scores are very low, then I might say might help to meet slightly more often. Do you agree? Most of the clients who are in this level of distress, a 2 on the ORS, would readily and heartily agree. I hope that gets it. Cynthia, should I move on? There were a number more questions here for people.
Yeah, there are also a number of questions coming in. We might have to have another one of these sessions.
Well, that would be
So
good.
it's, yes.
Okay, is there a particular question that you think several people have that we could address?
One of the questions is about, that a couple of people have asked about, is using how people are using the SRS and so on remotely.
So I think the best thing to do for those remote user questions, if you haven't seen them, and maybe you haven't, if so, I apologize, I don't mean to put you off, is to check out those blog posts from the last several months that look specifically at how do you administer the measures in an online environment. So if you go to my website, you'll be able to find those, I promise. And the last 3 are specific to how to use them in an online format. So I did want to mention, though, that several people asked about implementing FIT and the cost of it. And, you know, this is a really hard question to answer. If you're an individual practitioner, I would say the cost of getting started is really nominal. If you just want to play tennis, for example, and you've never played tennis before, you can buy a racket. You can buy a pretty cheap one at Walmart. You can go out and play, and you're likely to have a lot of fun. You might even get an instruction manual. You might watch some videos on YouTube. All of this is possible. If you are an agency and you're thinking of implementing, well, this is an entirely different question. And we have outlined in Manual 6 a series of 5 stages. And these 5 stages, when they are followed from the outset, are associated with more successful implementations. Because here's what we know about implementation in agency settings. As many as 70% of implementations fail. And if you've been part of an agency and you've implemented any of the so-called evidence-based protocols, you probably know that this is the case. And this can lead to a lot of cynicism on the part of clinicians. A new mandate comes, and the clinicians who've been at the agency for a while know that if they just wait long enough, the winds will soon blow in another direction. We don't want that to happen with FIT. So when people call me and say, I want to implement FIT, I usually say, can we talk about this? And they say, well, no, just send us the measures. I say, well, let's take this slowly. Why don't you begin with the first step, which is exploration, asking, are these the right measures for your context? How can you do that? Download the manuals, form an exploratory team, and read them together and see, does this make sense to you? You can also call and get an hour's worth of consultation from one of the FIT certified trainers. It will be money well spent before you go into the installation phase, which is the most expensive phase in the installation process. So once you've decided and explored, you think, okay, we're ready to take the first step. Installation means you're building the infrastructure, and that means training and generally software platforms. And the software platforms have options for when you buy multiple user licenses, and you can explore those with the various software companies that make them available. The training structure is to ensure that you have people on location that can actually lead the implementation process. And that's what we have the FIT certified trainer process for. FIT certified trainers go through 4 lengthy trainings. They have to pass an exam, and they have to submit a training video, which is watched by a group and rated, and people are given feedback. So the trainings include the advanced intensive, the FIT supervision training, the training of trainers, which is all about how to do training. And the last one is the fit implementation training. Having those trainers prepared and ready to go is the first thing you need to do before you move on to initial implementation. So we're 3 steps in before we even get to piloting. That's not what generally happens. What generally happens is I get a call, Cynthia gets a call, Suzanne Bargman gets a call, and it's the manager on the line. And they say, hey, you know, we downloaded these measures and we can't get our staff to do them. In fact, they hate fit. They don't want to hear any more fit stuff ever again. This is when we say, well, we know a couple things about implementation. We know that on average, a successful implementation is not something that happens overnight. It doesn't happen from a 2-day training. And by the way, the original research on using the ORS and SRS, the researchers said that this could be done in a day. You know, I was skeptical at the time, and I think the research has now backed this up. On average, successful implementations of fit, and just so you know, any evidence-based practice, take between 3 and 7 years. That's not because the staff is unwilling. There are institutional barriers to implementing any new idea. There's traditions and policies that have to be reviewed. We also know that implementation failure is more likely when the focus is on the intervention rather than organizational change. Let that sink in. I've told this story now twice. I'll tell it a third time on these fit webinars. I get calls, and the calls go something like this. Can we do fit and single session therapy? Because we're a single session therapy agency. That's interesting. In other words, they're focusing on the intervention and they're trying to fit into it. And what I say to them is, are you willing to change your mind in response to client feedback if it might require more than single session therapy? If they say no, then I know they're not interested in organizational change, and fit implementation is going to be really difficult. We also know that implementation failure is much more likely when the training is off-site and comprised of demonstrations rather than live on-the-job coaching. That's also why we think it's important to have that fit certified trainer on board and ready to go, and also consultation perhaps from other certified trainers within ICCE. And we also know, last but not least, and sincerely not least, that failure is more likely in implementation when the practitioners and supervisors are held accountable rather than an implementation team and the manager. If I can't get the manager to show up on the calls about fit or at the trainings about fit, the likelihood of success is really drops. So it really is critical to follow through those stages because we're one of the only evidence-based practices that we have data about how long it actually takes to implement an evidence-based practice. This is research that was done by our Norwegian psychologist and colleague Heidi Bratland. And here the cool thing is that, much like Mike Lambert's studies that I mentioned earlier, where therapists got feedback on half their cases, but the other half, they simply had the measures administered. In Heidi's study, they did the exact same thing. And at the conclusion of the study, she found that when clients met with therapists who were using the measures, those clients were 2.5 times more likely to demonstrate significant improvement. The problem is, as you can read on this slide, that for the first 2 years of the study, using the measures had absolutely no impact on effectiveness. And again, that's not because the therapists were resistant or they couldn't learn. It was because there are lots of institutional barriers, policies, and traditions that have to begin to change in response to client feedback. Here's a classic one. Here's just a classic one. Many agencies have rules about moving clients from one practitioner to the next in the absence of change. They have rules actually against that. Or an individual practitioner may not have people that they can reliably send their clients that they're not helping to. If the resources don't exist, and that's only one of the barriers, then the success of implementation is likely to be really constrained. How are we doing, Cynthia?
We're doing okay. There's one question about administering ORS and SRS.
Okay, should we ask that question, and then I can get in one more from Heidi Peterson?
Yeah, actually, this question is from Heidi as
Oh, it
well.
is. Ah.
Anyway, she's saying, how would you administer ORS and SRS if you have a period of doing outpatient sessions twice a week? This is when you were talking, I believe, about administering the ORS at the beginning of the week and the SRS at the end of the week. She goes on to say, doing it as a set, like in group therapy question. And it's just noted that it almost feels odd not to do it at each session.
Yeah, you know, if you're meeting a client twice a week, the likelihood of much change and that change will last and be meaningful between visits is really very small. So if in fact you're telling the client this is kind of a unit of service, we're going to meet Tuesday and we're going to meet Thursday, and that's sort of one full session, especially if this is a protocol driven treatment that you have material that you have to cover and deliver the treatment in this fashion, then I would say ORS at the beginning of the first session, SRS at the end of that first session. And now that you're mentioning this, Cynthia, let me just say that in a setting where you have multiple team members, so maybe it's Heidi doing one kind of care and somebody else working on mindfulness, you don't want each person within that organization to be administering the scales during the same week either. And the example I usually give is if you were working in a hospital setting and you went to floor number 1 and they said, well, you have to have your blood drawn so that we can help you. So you have your blood drawn. Then you go to meet another professional on the second floor. You don't want them to draw your blood again. Rather, you want them to look at the values of the test in the system. So what this demands of a system of care, and perhaps why it takes so much time to implement, especially in a complex system where you have physicians and psychologists and social workers and case managers, nutritionists, exercise physiology, where you have all of these people working. You don't want each one of them using the ORS and SRS independently. You want them to look at the values in the system when the ORS was gathered. And you want whoever administers the SRS as late as possible in the week to ask about all the other services. Remember, it's not just my 15 minutes that we've been meeting, it's everybody you've met during this week. Take a minute and think about that before you complete the measure. The other question, and I think it's a good question to finish up here today, is from Ruth Rohn. And Ruth asks, what's most important to focus on as you start to collect feedback from clients? And I'll tell you, not only is this the most important when you first start, but it is the problem that I see, and I know Cynthia will confirm, she sees when she's doing consultations at agencies or with clinicians working to implement feedback-informed care. And that is the culture of feedback. Creating an atmosphere, a milieu around completing the scales in which your client feels that you're really truly interested in what they have to say. And secondly, that what they say will be used to guide, inform, and change the therapy. So we have sort of a set pattern that or a set script that we use rather when we're introducing the scales. For the ORS, I say, I work differently than you may be accustomed to. I'm really interested and dependent on you letting me know whether this is helping you or not. And so at each visit, I'm going to ask you to fill out a simple scale. And on that scale, it's going to ask you, how were you doing since we met last? If what you do, if what we do here helps you, that's great, we can keep meeting. But it's really important to know if it's not helping or only helping marginally. Because if that's the case, then you and I can talk about what we can do differently. And if that doesn't help, I can talk about where else you might be able to get some additional help. And if that doesn't work, then don't despair. I'll work with you to find someone else or someplace else that might be of more help to you. That's my commitment. I'm committed to the outcome. So, and taking the time to develop that culture of feedback, we think is a critical first step. And with that answer, it brings us right up against the end of the hour. I want to thank everybody for joining in. I know that there were questions that we didn't get to. Cynthia and I will be sending out an email announcement for our next meetup and get together on June 3rd. Thanks everybody for joining us. Thank you, Cynthia.
Thanks everyone for all your questions. And bye-bye.